Hello, welcome to your online lecture for the course Altered Physiology 1. In today's lecture, we're going to be discussing reproductive disorders. This is the first part to a two-part series on this topic, but today we're going to be looking at breast cancer, testicular disorders, prostate disorders, and sexually transmitted infections. We'll begin the lecture by talking about breast cancer. We're going to look at this graph on the left. And what we can see from this graph is that the United States of America has the highest incidence of breast cancer, followed by the Netherlands and Sweden. And China has the lowest incidence, followed by Japan. And so we can say that breast cancer really seems to be a cancer then of the developed world. Now, when we talk about incidence, in the case of this graph, we're talking about the number of new cases of a disease that come up. But what's interesting, though, is if a person from China, where we know the incidence is a lot lower, moves to the United States, their risk of breast cancer, the risk of breast cancer for that person's daughter is the same as it is in the United States. Now up here on the right of the screen, we're going to look at age ratio, really your chance of being diagnosed with breast cancer. And you can see that your chance of being diagnosed with breast cancer at a certain age is going to range. And it's obvious then that there's going to be this increase in the development of breast cancer with increasing age. So you can see that when you're between the ages of 30 and 39, you have a 1 in 238 chance, but once you're up to 60 to 69, you have a 1 in 27 chance. So definitely age does contribute then. Mammograms, which are used to help detect breast cancer, they generally start around the age of 50, and this is because it's around this age that they're found to be the most valuable when you look at risk versus benefit, which we will talk about later. And we're going to look at statistics here. This is from Statistics Canada 2016, so it has changed a little bit since then, but not enough to change the overall picture, which is that when you have a look at males versus females in terms of the number of new cases of cancer, you can see that breast cancer makes up over 25% of the total amount of cancers that are diagnosed in women, and prostate is 21% of the total amount of cancers diagnosed in males when we're looking specifically at male versus female. And so collectively then, we really have prostate and breast cancer as being really reproductive disorders or reproductive cancers. And we'll talk about prostate a little bit later today as well. Our top 4 cancers then are prostate, breast, colorectal, and lung cancer. But relevant to this topic now is that a quarter of breast cancer makes up about a quarter of all cancers that, in terms of new cases, that were reported in 2016 or diagnosed in 2016. Let's look at risk factors now for breast cancer development. You can see that this slide is using what's called relative risk. The risk factors are listed here. If we look at these top risk factors here, being female, increasing age, family personal history of breast cancer, inherited genetic mutations, high breast density, and atypical hyperplasia, it's associated with a relative risk of greater than 4.0. And what this means is that if you possess any of these risk factors, you have a 4 or greater times the risk of developing breast cancer than somebody without these risk factors. And so this would be considered, these risk factors here, and their associated relative risk would be considered high risk. Beneath that, we have what would be moderate to high risk, so a family history, a high dose radiation to the chest or the breast, and prior benign breast disease. But what's interesting is that mammograms, which are used to actually diagnose breast cancer and find breast cancer, also put you at risk for the development of breast cancer. And so that is why they're not done all the time with women of all ages, and we'll come back to that a little bit later as well. And then we can see that we have lower risk really low to moderate risk as well, which includes somebody who's never had a full-term pregnancy. Maybe they had a late age when they were at their first pregnancy, and all this has to do with hormones, including early menarche, so exposed to certain hormones at a younger age, or late menopause, meaning that there's a greater span that you're exposed to hormones. If you've never breastfed a child, if you consume a lot of alcohol, smoke, oral contraceptive use, hormone replacement therapy, and those that are inactive or obese, which is more common becomes even more common in postmenopausal women. Now, it's also important for you to understand the difference between modifiable versus non-modifiable risk factors. So there are different variables here that can be modified versus those that cannot in terms of your choices. And so if we look at the bottom part here, certain things are in your control. The decision to consume alcohol, the decision maybe to not breastfeed children if you're given that opportunity, the decision to smoke or use oral contraceptives or become physically active, or to have various different high-dose radiation done to the chest or breast. All of this increases your chance of developing breast cancer, whereas many other variables, such as what's listed here, where we have our higher risk, and then a little bit as well within our moderate to high risk, are not modifiable. Continuing on with breast cancer, most breast cancers arise from ductal epithelial tissue. And so the most common type of breast cancer then is called ductocarcinoma. It's associated with the ducts, as the name suggests, and the ducts are what are used to deliver milk. And so the ducts are actually different than the fatty tissue or the muscle tissue of the breast. Since 1980, the widespread use of what's called screening mammography has led to this epidemic of the diagnosis of ductal cancer. Mammography is a very specific type of breast imaging that will use low-dose x-rays in order to detect cancer early, so really before women are experiencing any actual signs or symptoms that would correlate with breast cancer. And of course, before somebody has any signs or symptoms in the early stages, this is when it's most treatable. 2/3 of breast cancer occur in women that are older than the age of 55. And so even with the risk that mammographies pose, or mammograms pose, when we talk about risk of breast cancer, even with that risk, after the age of 55 or around the age of 50 and up, it makes sense to be using them in women at this age. The most common location for breast cancer to begin is within the upper lateral quadrant. And so that location then would be right up here. So you can see 47%. You don't need to know those specific statistics, but know that the majority, that's very important, the majority of breast cancer is going to be within the upper lateral quadrant. Very close to the arm, and so very close to the armpit, where we have a lot of lymphatic vessels present. You can see that a little bit better here in this image. Making spread higher, because once cancer gets into the lymphatic system, we know that it can spread to other lymph nodes, into our lymphatic system, and then to distant organs as well. Okay. And so location determines lymphatic spread. That should be pretty clear. If you have a tumor here in this quadrant, then it's going to spread to the armpit lymph nodes. If you had breast cancer more towards the sternum or the breastbone, then it's going to be more likely to spread to lymphatics in that region that's closest to it. Now let's talk about lymphatic node involvement specifically. We're going to talk about the sentinel lymph node. The sentinel lymph node is involved only if cancer is in the lateral part of the breast. And here you can see that if this is cancer and this is the sentinel lymph node close to the axillary or armpit region, that if cancer is within that upper or lower lateral part of the breast, then it can spread into that sentinel lymph node, where it can then spread to other lymphatic structures. Sometimes the sentinel lymph node is biopsied when breast cancer is suspected because it is the lymph node closest to the tumor, and it would likely be the first contact if spread does begin. And then, as already mentioned, if the medial portion of the breast is affected, then it may spread to the sternal region, or what we would call the mediastinal region. Clinical manifestations of breast cancer include a painless lump that can be felt, dimpling of the skin, where the tumor beneath the skin can sort of pull on the skin tissue, causing dimpling. Lymphedema can occur. What we mean by that, so this is edema or swelling caused by lymphatic buildup. If you have a tumor that is putting pressure on lymphatic structures, preventing the lymphatic system from properly draining excess fluid as it normally does or can do, then that fluid will remain where it is and cause lymphedema in different regions of the upper part of the chest and arm. And skin retraction can also be seen, somewhat coinciding with the reason I talked about with dimpling of the skin, where it just changes the dermis above it, and nipple retraction as well. If the tumor is located somewhat close to the nipple, it can cause the nipple to retract backwards. So the final comment on this slide to make is that in some cases, mastectomies need to be performed. Ectomy has to do with removal, mast has to do with the breast, and when these are done, sometimes they'll have to remove part of the breast, all of the breast. They might have to remove some or all of the lymph nodes in that area. And the problem with removing lymph nodes within this region is some of the lymph nodes within the arm are going to actually be draining the arm. And if the arm is not being drained properly, then lymphedema can result. And if this happens, the person will oftentimes have a lot of discomfort throughout their arm because their lymphatic system just can't pick up that excess fluid. Cancer can be staged according to what's referred to as the TNM staging system, the T standing for tumor, N for nodes, and M for metastases or spread. So when we look at tumor, when we're talking about breast cancer, and this is actually a specific example with breast cancer, is that a T of 0 implies that there is no growth, no cancer, the breast is free of a tumor. Whereas once you get to T1, this represents that a lesion is less than 2 centimeters in size. T2 is the lesion is between 2 and 5 centimeters in size. And then T3, you can see that there's actual invasion of the skin and or the chest wall. So it's contained here, but with T3, it's grown so large that it has invaded. Not necessarily spread or metastasized, but invaded tissue around it, which increases the odds that it will spread. And for nodal involvement, you can see that no nodes are involved with N0, which makes sense. With N1, it says that you have mobile nodes that are involved. This isn't overly clear, but what this really means is that if somebody has a staging of N1, it means that some cancer cells have reached one or more lymph nodes usually in the immediate area. And then you can see with N2 that you have multiple nodes that are involved and have been infiltrated by many, many cancer cells. And then with metastasis, if you look at this image, bone, lung, and liver tend to be the areas that cancer can spread when we talk about the breast. And so, of course, with M0, there is no metastasis. You can see with M1 that there is metastasis present. It's obviously present in another organ, but with M2, much more concerning. This is where there's lesions kind of all over the place in different areas, and so metastasis is suspected to be in multiple organs. If we look at these images of mammography, it shows you what, in this case here, this is a tumor. But when we talked about how we generally don't do mammograms in women who are under the age of around, let's say, 55, it's because of what the breast tissue looks like when you're young. Normal breast tissue, if you look at this normal young healthy woman without breast cancer, normal breast tissue shows lots of different collagen deposits that look like masses, really, which make it difficult to detect breast cancer with mammograms at this young age. So if you use a mammogram on a young female, it's going to be very difficult to determine if they have any lesions here because of all the normal collagen deposits that are present. So you're putting that increased risk by using a mammogram when it's going to be very difficult to use that mammogram to detect cancer to begin with. And then if you look at the postmenopausal woman, where there is a substantial reduction in collagen, making any collagen deposits that are present quite suspicious. So if you see something like this in a postmenopausal woman, it's likely not a deposit of normal healthy collagen, but rather some sort of growth. So it's easier to identify in women who are over the age of 55, certainly postmenopausal. On our final slide discussing breast cancer, we will look at metastasis and where the most common sites are when somebody has breast cancer if it is to spread. The most common metastasis sites for breast cancer, which would really, for the most part, be found on autopsy, would be the lung, so lung and pleura is part of the lung as well, the liver and the bone, and then followed quite a bit down by adrenal glands of the kidney. With breast cancer, if the cancer does metastasize, it is common that it will metastasize at multiple sites. If we look at breast cancer staging, which these are relatively general statements that can apply to all different types of cancer as well. But with stage 1, you're generally the small contained tumor. Stage 2, it spreads to lymph nodes in the area. Stage 3, the tumor's grown quite a bit and it's invading, in the case of breast cancer, the chest wall and the skin in the area. And then with stage 4, this is where you've got spread to distant organs, with the lung, as I said, the liver and the bone being the most common sites of metastasis of breast cancer. When it comes to the bone, oftentimes people will present with what's called a boring pain, which is this type of pain that can be felt really deep within the body, deep within the bones. All right, now let's move on to the boys and talk about male reproductive disorders. I wanted to go over just a little bit of relevant anatomy, although we've talked about this in recent classes. But if we're looking at this sagittal view here, we can see the bladder and we can see the urethra coming off the bladder. We can also see the prostate here that surrounds the bladder. So we'll talk about the prostate today. And you can see the testes, which there would be 2, but each are contained within the scrotum, which is the sac that holds on to the testes. So we'll talk about different conditions that affect the male reproductive system or anatomy, and what we'll look at specifically is benign prostatic hyperplasia, which we've talked about in the past already. We'll talk about prostate cancer, prostatitis, cryptorchidism, and testicular cancer. Starting with benign prostatic hyperplasia, or BPH. This condition is defined by hyperplasia, which we know is an increase in cell number of the prostate glands or the connective tissue stroma, which is part of the prostate. And sometimes it can be confused with prostate cancer, and we'll look at prostate cancer after we talk about BPH. This condition usually begins in the inner layers of the prostate, so we're talking about inner layers through here rather than the outer component. And when this happens, when you get this increase in cell number and really this growth here, as you can see, of the prostate, it's going to put pressure on the urethra and it's going to put pressure on the bladder above. So this condition can lead to partial obstruction of the urethra, which you can see it can lead to urine retention. If you can't push all of that urine out of the bladder through the urethra, then you'll retain some of it within the bladder, which then increases your risk of urinary tract infections and can even increase your odds eventually of upper urinary tract infections, as we discussed in the urinary tract disorders lecture. And there is also an increased risk of urolithiasis, which is the formation of stones when you're retaining urine, and an enlarged bladder. So what happens is the bladder is working really hard to try to push urine out of it into the urethra, because it will continue to fill as the kidneys produce more urine, so it needs to get rid of urine in order to replace it with new urine, and it can't do it. It's having a hard time working past this obstruction. And so what the bladder does is it says, okay, well, if I'm going to really work to push past this obstruction, I'm going to have to get bigger in order to do it. So the bladder itself will undergo hypertrophy of the smooth muscle that makes it up in order to push past this obstruction. Okay. Now we'll move on to prostate cancer, which, as I mentioned, can mimic BPH. So if you have an enlarged prostate from BPH, or you have an enlarged prostate because of growth of cancer within it, it can present with some similar signs and symptoms, especially initially. Like many cancers that you've heard about in this course so far, prostate cancer is an adenocarcinoma. Remember, an adenocarcinoma is a cancer that begins in glands. So the adeno part is glands. And maybe recall that carcinoma refers to a cancer that arises from epithelial tissue. So that's the tissue that lines organs. Now, it starts in the periphery of the prostate and tends to grow very slowly, which is a really great feature when you're talking about a cancer. So remember that with benign prostatic hyperplasia, we said that it begins in the inner layers of the prostate through here, whereas prostate cancer, it starts in the periphery of the prostate, so the more outer component. So because of its slow growth, it's oftentimes monitored rather than operated on immediately. So when it is determined that someone has prostate cancer, a watch approach might be taken. Prostate surgery has been linked to other disorders such as urinary incontinence because of proximity to the bladder and the urethra, and erectile dysfunction because of proximity to the penis. So this watch and see approach and certain therapies might be done rather than a surgical approach. And again, that's because it does grow fairly slowly, so it's worth maybe waiting to see how things progress. Clinical manifestations, or those signs, symptoms, or evidence of a disease, is that it's going to be similar in presentation to BPH, which makes sense based on what we just talked about. There's also an increased incidence of urinary tract infections, obstructions, urolithiasis, and upper urinary tract obstructions such as hydroureter and hydronephrosis, all of which we discussed in a lot of detail during our urinary disorders lecture. Staging of prostate cancer has to do with Gleason scores. So what we have here are different grades, Gleason grades. This is a system of grading prostate cancer cells based on how they look underneath a microscope. So the cells, when you look at them under a microscope, will range from being very well differentiated, meaning you can tell exactly what cell type it is, to undifferentiated, where you look at the cell type and you say that this looks nothing like the tissue that it's supposed to, or the tissue that it came from. Generally speaking, the higher the Gleason score, which should make sense when you read these descriptions, the higher the Gleason score, the more aggressive the cancer and the poorer the prognosis. Here's showing you prostate cancer growth, this lump in the image. And if we look at this image on the bottom right, it's showing the percentage spread to other organs, with the lung, so lung and pleura, the liver, and the bone being the big locations of spread, but with bone being the greatest. So look at this number here, very high, 90% will metastasize to bone if it's going to spread. You might remember the name Jack Layton, who was a leader of NDP in, I think, 2010, and he had announced that he had prostate cancer, but he had a sudden leg break due to spread to bone, as we know prostate cancer can do. Moving on to another condition of the prostate called prostatitis. The itis component, we know what that means, being inflammation. So this is swelling and inflammation of the prostate gland. And the reason for the inflammation is, well, there are a variety of different causes, but pathogens such as bacteria can lead to prostatitis, and it can manifest itself or present very similar to a urinary tract infection where painful and or difficult urination can be present. And just to remind you what the prostate does, it is a gland that produces fluid where it adds to the semen that nourishes and transports sperm out of the body. Okay, we'll move on to another condition now that affects the testes, and it's called cryptorchidism. Crypt means hidden and orches means testes. And this condition occurs when the testes actually fail to descend completely, and so they can remain in the abdomen where they initially form, so in the abdomen. They can move into the inguinal canal, so this inguinal region here, or they can end up at the suprascrotal junction. Supra is above, scrota is scrotum, referring to the scrotum, so they can just remain above the scrotum, instead of descending all the way where they're supposed to go, which is residing within the scrotum. These three that I mentioned to you, abdominal, inguinal, and suprascrotal, these are considered true cases of cryptorchidism, so true cryptorchidism, where they just will, instead of moving along this pathway, they stop somewhere along the way and stay there. There's also another type called ectopic, and this is where when the testes forms in the abdomen, instead of moving down again where it's supposed to reside in the scrotum, it takes a different turn. It actually goes off in a direction that's completely different than the pathway that it's supposed to go. So instead of just stopping along the way during its descent to the scrotum, it takes off a completely different turn and can end up somewhere completely abnormal. You can think of with ectopic is that it sort of just wanders off. Now, this condition can affect 3 to 6% of full-term males and 20 to 30% of premature males. Most, though, cases of cryptorchidism will descend by the first birthday naturally without intervention. So you don't need to know the percentage, but be aware that there is a higher percentage of premature males that are affected with cryptorchidism than full-term males. So it needs to be watched for if somebody is born premature. And one of the components of a regular checkup of a baby when they're born and then checkups after that are to ensure that the testes actually did descend into the scrotum. Now, if it doesn't descend and it's left untreated, then it can lead to infertility or at least reduced fertility and testicular cancer. The reason for infertility is because the testes normally will reside in the scrotum, which is outside the body, because the internal body is at too high of a temperature for the sperm to survive. And so that's why they reside outside of the body. So again, infertility because the testes then are kept at internal body temperature, which is damaging to the sperm. Okay, now we'll talk about testicular cancer. This is most common between the ages of 15 and 35, so young people. Those that are taking this course, you would apply to this. So this is very important consideration to check yourselves really in the same way that women should be checking their breasts for any lumps that could be related to breast cancer. The most common type is called a germ cell seminoma. Testicular cancer generally responds very well to treatment with a 95% cure rate, so that's huge. Very important that if somebody has testicular cancer, knowing that their prognosis, if it's caught, is very high, but that's if it's caught. And a lot of times the only way to catch it, especially in the early stages, is to check yourself. So make note of that for your own health and well-being and any family members or friends you have as well. The risk factor is a history of cryptorchidism, which we just talked about on the previous slide. So in other words, if a person's testes does not descend on its own, then it is at risk of developing testicular cancer. I already talked about how it's important to detect it and can be easily detected with a good self-exam. So just another reminder to all of you males. Generally, it presents with a painless testicular enlargement, which may not be noticeable unless it's looked at or felt. There could be a change in the size or shape of the testicle, swelling, thickening of the testicle, a firm, smooth, slow-growing lump within the testicle. So that slow growth gives it an advantage and gives the human an advantage in beating this type of cancer because of its slow growth. Same with prostate cancer, as mentioned earlier. There can be a feeling of testicular heaviness because there is a growth there that normally should not be there. And in terms of metastases, it can occur. So if it's undetected, it can spread in particular to the retroperitoneal lymph nodes. So these are lymph nodes that are located sort of behind the peritoneum, and the lungs and the brain are common locations of spread. Sometimes the retroperitoneal lymph nodes will actually be removed because we know that this is one of the first locations in terms of lymph nodes, for the cancer to spread if it's going to. Okay, now we'll talk about sexually transmitted diseases, and there are so many different ones. We're going to, for a moment, categorize them into bacterial, viral, protozoan, and fungal, but we're only going to be looking at a very few specific types of STIs. With bacterial, you can see examples of chlamydia, gonorrhea, and syphilis, which we'll talk about today. Viral includes herpes and HPV, which we'll talk about. Protozoan, an example is trichomoniasis. And a common fungal example is candidiasis, which we will not be talking about today. So we'll be focusing on these top two groups, being bacterial and viral. We'll talk first about prevalent bacterial STIs before we move on to viral. These three are the most common: gonorrhea, syphilis, and chlamydia. The more appropriate term based on the bacterial name is Neisseria gonorrhea, Treponema pallidolum, and chlamydia trachomatis. And you can see that with chlamydia and gonorrhea that the name itself is within the bacterial name, which is helpful for recognizing them. We'll start with gonorrhea. This is caused by a bacteria, obviously, as all of these three are, but what happens here is the bacteria will infect in a female, the endocervical canal and the urethra in males or females. Now, what's the endocervical canal? I don't have a picture, unfortunately, to show you, but if you can picture the female cervix and the uterus and the canal that would run through the cervix, allowing for really communication between the uterus above and the vaginal canal beneath. So again, the endocervical canal then is really a passageway then from inside the uterus to the vagina, and it can be infected by gonorrhea. But as I said, also can the urethra in males and females. What can happen is, let's say we have a female that's infected with gonorrhea and it isn't detected right away. Okay, so our endocervical canal is infected. This bacteria can continue to ascend and cause pelvic inflammatory disease. So we're talking about a female in this case. What pelvic inflammatory disease is this infection caused by bacteria, and the bacteria can impact not just the cervix in this case, but it can also impact the uterus, the fallopian tubes, and the uterus, causing overall infection within the pelvic region in females. And the reason it doesn't affect men is because it is a disease of really the uterus, fallopian tube, and fallopian tubes. Okay, so In terms of clinical manifestations, mucopurulent discharge, which is the emission of a secretion of fluid that contains both mucus and purulent means pus, it is common. Okay, so people with gonorrhea then will commonly have a mucopurulent discharge. But because of the location of the urethra and the cervix in females, sometimes this mucopurulent discharge gets mixed up with other discharges and may not even be noticed, at least initially. But with men, when they start to have this mucus, pussy discharge that comes out of the urethra at the tip of the penis, it can be pretty obvious that something is wrong. So it can be, gonorrhea then can be more commonly or have an earlier diagnosis or identification in males compared to females. If the urethra is infected, another common presentation can be burning with urination. Okay, let's move on to syphilis. I know this is not the nicest of topics, but it's certainly an informative one. Syphilis is caused by the bacteria Treponema pallidolum. As already mentioned, it progresses in stages from primary to secondary to tertiary. With primary, there is this skin ulcer called a chancre. And not a canker, but a chancre or a chancre. And it's found on the penis or the vagina. And you can sort of see it on this image here. And these are painless, and they're non-itchy, and they're firm. But if you're not looking for it, especially in females, if you're not looking for it, you may not notice it. Males, on the other hand, are more likely to notice if they have a presence of a skin ulcer or that painless chancre found on their penis. Then once it progresses to secondary, this is when the bacteria enters the system, your body's system. It becomes systemic, but it's still considered mostly asymptomatic at this point. There are some people that can present with a rash on their hands and their feet that coincides with secondary stage of syphilis, but that's rather uncommon. Then tertiary, this is rare because it's usually caught before this point. Tertiary syphilis can actually travel to the brain. That's why it is represented by neurosyphilis. It can infect the brain, so it can lead to a neurologic presentation. Another important note to make is that congenital syphilis is possible. This means that if a female has syphilis, she can pass it to her unborn baby, so it can pass through the placenta to her unborn baby, and her baby can be born with syphilis. Congenital syphilis is a very severe, disabling, and in many cases a life-threatening infection that is seen in these infants that are born with this condition. So if a female has syphilis, it's a very important piece of information to identify before they get pregnant or in the early stages of pregnancy. So what we can say then is that syphilis can pass through the placenta. Gonorrhea and chlamydia do not, but I'll bring that up again in a moment. Let's go over chlamydia. Chlamydia is caused by the bacteria Chlamydia trachomatis, and it also can infect that endocervical canal, again, that canal that runs through the cervix, from the vagina to the uterus. It can also impact the urethra. So it can impact the endocervical canal or urethra in females and the urethra in males. So in that case, it has some similar presentation than to gonorrhea in terms of the location. The urogenitals can be affected, so this is where we're talking about the urinary tract being affected, and it can cause inflammation of the urethra as well. So it can present similar to a UTI. It can also cause pelvic inflammatory disease. So what we can say here is that both gonorrhea and chlamydia in females can lead to PID, or pelvic inflammatory disease, which is that inflammation of initially the cervix, but the uterus and the fallopian tubes as well. This condition of this infection of chlamydia is most commonly seen among young heterosexual people with multiple partners. So in university settings is an example of what we're talking about when we say young heterosexual people that have multiple partners. It can spread quite quickly. And for the most part, it is asymptomatic, meaning you don't know that you have it, which means it can be easy to pass on. But we have an example here of chlamydia where the cervix is very, very red and very engorged. However, you're not going to know this unless your cervix is being looked at like it might be or would be in a vaginal exam. Now, I just wanted to come back again to what I spoke about with congenital syphilis. So I said congenital syphilis is where the mother that's infected with syphilis can pass it on to her unborn child. And the way that she's passing it on is through the placenta. So syphilis then is bacteria that can cross the placenta and infect the baby. And then they're born with the condition. Gonorrhea and chlamydia. If we have a female that's infected with gonorrhea or chlamydia, can she pass it on to her baby? Well, yes, but not in the same way. It does not cross the placenta. Gonorrhea and chlamydia do not cross the placenta. However, what happens is because it infects the vaginal region, when the baby is born and delivered vaginally, they can contract gonorrhea and or chlamydia. Oftentimes, preventative antibiotics will be put in a baby's eyes when they're born just in case they do contract a sexually transmitted bacterial disease during a vaginal delivery. We'll finish off this lecture by talking about the prevalent viral sexually transmitted diseases. We'll look at genital herpes and human papillomavirus and AIDS as well. We've already talked about AIDS in this course, so we won't go into detail, but just know that it is or remind yourself that it is a virally transmitted, sexually transmitted infection. So starting with genital herpes, we'll start by looking at this chart here relating to genital herpes, and you can see that once you'll start, of course, with sexual contact, and then over time you'll develop these lesions. And then when these lesions develop, you're going to say, oh, these are odd lesions. They're painful blisters and ulceration. So, well, I'm going to have to go see my doctor. So this is where you'll contact your practitioner. People generally wait a little bit of time, either because they can't get an appointment or they think they're just going to go away. Then new lesions can continue to form, but then after a period of time, the lesions will start to heal and the symptoms can disappear and then heal completely. But then this is really a latent period of time where the infection disappears for a while, but can come back. So the latent period is where no symptoms are actually present, even though the person is still infected. Congenital herpes is common. We talked about on the previous slide congenital syphilis. So this means that somebody with genital herpes can pass it on to their baby and be born with it. But how is it that the baby is actually contracting the herpes? Well, it's because it's coming into contact during a vaginal birth with the infected lesions and can be born then or be infected with genital herpes. And the thing with genital herpes is even during the periods of time where it's not considered active and there's no obvious signs or symptoms, then it is still possible to pass it on. The virus can still shed and be passed on to other people. Human papillomavirus, or HPV, can cause genital warts and can cause cervical dysplasia. The most common strains that cause genital warts are HPV strains 6 and 11, and the most common strains that cause cervical dysplasia include 16 and 18. So these strains of HPV are more likely to cause cancer, cervical cancer in women, because remember, a female with cervical dysplasia is at increased odds of developing or increased chance of developing cervical cancer if the dysplasia is not removed and those cells are not removed from the cervix. And AIDS, I said that we'd spoken about this already in a previous lecture, but it is a viral disease that can be passed on through various types of sexual contact with an infected individual, among other means. And we know that it starts off as HIV, which is human immunodeficiency virus, and can become acquired immune deficiency syndrome if it's not kept at bay. And the final point I wanted to make is that herpes simplex virus 2, that causes most cases of genital herpes, is different than herpes simplex virus 1, which is the virus that causes cold sores. That is the end of your lecture covering the first component of Reproductive Disorders 1, and you can follow it with the second lecture on this topic. Thank you so much for listening. Bye for now.